Today, I'm excited to welcome in the studio for the first time. And it's encouraging to me because this gentleman has been someone that I have actually known about for 16 years. And I heard his name repeatedly, time and again, from my predecessor, Duke Anderson. I'm like, I've got to meet this John Barnas guy. For those of you that live in Michigan, that work in rural health, you certainly know John because of the work that he does for hospitals like Hillsdale, as well as critical access hospitals, and bigger systems obviously know him as well. But executive director of the Michigan Center for Rural Health. And John, you have been now at the center for how long?
I've been at the center now. I started November 7th. I looked this up. November 7th, 1994.
94.
And I've been executive director since February of 2000.
Oh, wow.
Yeah,
That's incredible. So we're going to talk about your journey in a minute, but, you know, the work that the center does is incredible. And the advocacy that you do is, you know, on par with major organizations. It truly is. And when I talk to my legislators that represent my district, they know about you. They know about the work that you're doing. And I think it'll lead to our greater discussion about the importance of rural health in the country, but in the state. But, you know, obviously it's been quite a go. It's been a go lately. A lot of challenges.
A lot of challenges.
Yeah. And before we jump into some of those, John, why don't you give our listeners a little background about you and the center, if you could, please. You know, when you got there, what you did, and then where you've been. You've migrated for 30 years to something that's very beautiful.
Sure. So, you know, prior to me joining the center, I was at an FQHC.
Okay.
In Battle Creek.
Did not know that.
Yep. I was director of program development for almost 5 years.
Okay.
And before it was an FQHC, I was there with North Avenue Women's Center, which is, it's now part of the FQHC, and I got hired as doing some research on OB, Medicaid OB.
Oh, wow.
Yeah, the Kellogg Foundation had funded this women's center using one OB obstetrician and 4 certified nurse midwives, and to address the infant mortality rate in Battle Creek. And we were seeing all of the Medicaid patients in Battle Creek and the surrounding area with very good outcomes.
And that was probably at a time when CNMs weren't very popular, right?
I had never heard of them,
Yeah.
and I became sold on their ability
I agree.
To provide outstanding care.
And we deploy them here now.
Do you?
Yeah,
That's
absolutely.
great. Yeah.
It's an
So
important
then,
part of the model.
so after we were doing that for a while, we found out that it was you really can't tackle infant mortality without some really outstanding pediatricians, and so we replicated the model through another Kellogg Foundation grant, using a pediatrician and 3 pediatric nurse practitioners, and
Again,
we lowered
back then nurse practitioners still.
Yep, and so we kept on getting these modular units from the Kellogg Foundation when we were right across the street from Kellogg Community College. And then we wrote to become a FQHC. We didn't make it the first time.
Okay.
And then we reapplied. We had the help of consultant John Esselink, who since retired. He's living, I think, down in North Carolina now.
Oh, wow.
And great guy, great writer. And
Must have done something right.
We got it, and they kept expanding, and I think they now go by the name of Grace Health, I believe.
Okay.
Yeah.
And still it's under the FQHC
Yep,
guidelines.
they're an FQHC. So
for our listeners today, because there may be folks are listening from across the country, can you explain a little bit about FQHC, critical access, and mid-size vitals? What's the difference between the 3?
Sure. We always throw around acronyms, right?
We do.
So FQHC is Federally Qualified Health Center, and under one roof, you're going to see from birth until geriatrics, and you're going to also have social workers, dietitians, and dental, and you get cost-based reimbursement on your Medicaid and Medicare. And
is it a mandate, John, that they have to have these programs?
Yes, it is.
So it's all or none.
Yeah.
Or
you can contract it out too.
Okay, but they have to provide it.
Yeah, in some form or fashion.
Right.
And there's also a formula where they get a certain amount of money for the uninsured.
Okay.
So then, a critical access hospital, this is just another acronym by CMS, is a CAH, and it's a funding mechanism, and they also get cost based on their Medicare,
Right.
and then it's up to the state whether or not there's Medicaid.
Right.
So there's 35 CAHs in Michigan, and then of course you guys are a rural
Right.
PPS, Prospective Payment
Yep.
System Hospital,
Yep.
very good one. We're always very happy to work with you.
Thanks,
and
John.
yeah, you bet. It's a great community. And then there's certified rural health clinics, and they're
Yeah.
usually owned by, like, I think you have
We
a
have
couple.
several.
Yeah, you've
and
got
we're
some
actually applying. We have 2 more
Yeah.
coming down the pipe.
certified RHC rural health clinic, and that it's kind of like an FQHC, except an FQHC has to have a board of directors. I forgot to mention that, where 51% of the board is also patients. An RHC,
Oh, is that right?
Yeah.
I did not know that.
Yeah, and then you guys own an RHC. They're usually owned by a hospital. I think
Yeah.
probably there's like 220 or so in the state, certified RHCs, and I think there's only 15 that are independent, that are still private practice.
Yeah.
But most of them are owned by a hospital.
So, John, you said FQHCs was 51% community-based board?
Yep.
Really?
Yeah.
End users, so consumers.
Yeah. Yeah.
Is that right?
Yeah.
That can be different. I mean, that can add some
Well, you got a
unique
board.
dynamics.
Yeah, that can. It's
that-
good board meeting
Yeah,
discussion.
I bet you it is. I bet you it is. That's incredible. And obviously, all of those, whether you're FQHC, PPS, we're all under fire right now. There is, a lot of movement going on across the country with what we describe as the one big beautiful bill. And I call it other names for obvious reasons. And folks that listen to this know that we're certainly not fans of that because of what it does. But ultimately, right now, it's a challenge for hospitals. And we're going to get into that in just a minute.
Sure.
But before we do that, for the listener who may be in Texas, doesn't know John Barnas, is there a fun fact about you?
So I guess just a little background. Have been married to Patty for 25 years, and we're a blended family. I have 2 kids from previous marriage, and Patty has a couple, and we're all got 2. My son Caleb lives west of Boulder, up in the mountains in Nederland.
Oh, nice.
Yep, he's a gemologist. And then my daughter Sarah lives in Boulder, and she owns a organic wine store. There's a little fun fact.
That is
Yep.
fun.
Yep, and then Patty's 2, Laura and Julia. Laura's married. She works at SC Johnson. Her husband is a oral surgeon.
Oh, wow.
And they have 2 children, so I have 2 grandchildren. They live in Racine, so we can about a 4.5-hour drive. We'll get there when we can.
incredible.
And then our other daughter, Julia, lives in Charlotte, North Carolina. And she's engaged, JJ. She's going to get married in
Wow,
May. Yep.
congratulations.
Yeah, it's pretty
That's
cool.
awesome. That
Another
is
fun
cool.
fact.
Yeah.
And then the last fun fact is I'm a brewer, and right now I have 7 gallons of white wine that is fermenting in my basement.
Get out of here.
Sauvignon Blanc. I'll get you a
No
bottle.
way. Is that
Yep,
right?
Yep, I'll get you a bottle.
So that's a process.
It's a process.
And
Yep.
what was the passion behind that?
I first started brewing beer back in like
Oh, my
1999 or so. And
That's before it was popular with all these stands around.
It was before it was
country.
popular, and
Yeah.
before there was a lot of the microbrewers.
Microbreweries
Yeah,
and all
yeah.
of
Back when I started, there was like 25 of them in the states.
Oh, yeah.
So there wasn't many. And
Now
I
they're on
just
every corner, like Walgreens,
yeah, there is.
There really is.
But I just enjoyed it.
That's incredible.
Yeah, I was brewing beer, and Patty said, she doesn't really like beer, and so try making
wine.
wine. It's like,
Yeah.
sure. So
Oh,
There we
yeah.
go.
So here it is.
Yeah.
So now for the gemologist, so do you have to, I mean, you're buying your wife some nice diamonds, I'm assuming then, and she gets to, your children
Well,
get to inspect them.
here's the secret. Whenever you buy your spouse or whoever you're going to buy jewelry from,
Yeah.
see when you get your GI, it's a Gemological Institute of America. It's in San Diego.
It's all legit.
It's all legit. Yep, it's expensive.
rated and
Yep, and it's international. People come
Yeah.
from all over the world to get their GIA. Fun fact, if you get one answer wrong on your final exam, you don't pass. So you
Is
have to
that
start
right?
over. Yep.
so it's a real deal.
It's deal. And so
Yeah.
you can either get your degree in gems or diamonds. And Caleb got his in gems. And so when you're going to buy your beautiful wife something and
Yeah.
it's going to be a gem, make sure that when you buy it from someone on their wall, they have a certificate that says the GIA.
That is a fun fact, though. So that's great.
Yeah.
That is incredible. Well, we're excited today. In this episode, we'll talk about how rural healthcare professionals and organizations can prepare their states for the impact of funding cuts at the federal level. We'll talk about the Rural Health Transformation Fund, how to navigate HHS, and all of the guidelines coming from CMS and others, and of course, what all this has to do with rural health. So, John, let's first start because the Michigan Center for Rural Health, you have grown this organization with programs. And I really want to get to the heart of what you do because you do a lot. I mean, I'm getting an email, it seems like every week, about a new program, OB driven, this driven, that driven, quality.
Hope I'm not bugging you.
No, I love it. I love it because we've partnered very well. And it's improved the quality of this hospital because of the work that you've done. So help our listeners understand because there's maybe some confusion between the hospital association and then what your association is, because each state can have two, even more than that, obviously. But what is it that you do daily, and what is the value added to those respective hospitals?
Sure. So just to level set everything. So every state has a state office of rural health.
Okay.
And the program was started by Congress as a partnership with states back in 1991. And they gave the states the ability to create their own state office of rural health. So back in 91, 37 states decided to create a state office of rural health in their state government.
Yeah.
So, for instance, in Indiana, Ohio, the state offices are inside their departments of public health.
Okay.
Another 10 decided to put their state offices of rural health, SORHs, in universities.
Universities, yeah.
So, my colleague John Ike from the University of Wisconsin-Madison,
Yeah.
Lisa Davis at Penn State University. And then there's three of us that the states decided to create nonprofits, Michigan, South Carolina, and Colorado. And if you were to ask Tom Morris over at the Federal Office for Health Policy, which is part of HRSA, which is the best model, he would say that the nonprofit model is.
Yeah.
Because I have a board of directors.
Yeah.
And so I report to them. We live at Michigan State. That's why my email address is at msu.edu. We've always had the dean of COM, College of Osteopathic Medicine, on our board. Right now that's Dean Joyce DeYoung.
Yep.
She's wonderful,
Yep.
fairly new. Then we have representatives from the MHA. So representing the MHA is Hunter Nostrand, who's the CEO at My Michigan Alpena.
Sure.
Representing the Michigan Association of Local Public Health is Nick DeRusha up in Eastern UP at LMAS, District Health Department. You probably know,
absolutely.
know him. So we got a board. So, what Tom would say and what I will say, what makes us different and unique and a lot is our nonprofit status allows us to open our portfolio to more opportunities than because you can be a little restricted in the state government, a little less so in a university setting. And in a nonprofit setting, my board of directors, which is wonderful, Dr. Ned Canfield is the chair, Dr. Al Ferreira is the immediate past president, Beth Nagel is on our board, and so is Nick from LMAS. Yeah. And then we have a number of other board members. There's 12 of them, and for them it's like, John, assemble a good team, find the best people, and I always hire people who are smarter than me, and then find the funding.
It's great, isn't it? Yeah.
And find the funding.
Find the funding so they can do what they need to do.
Yeah, and so we're managing. We just are about to get in and sign a contract for a 17th different grant that we'll be managing to help improve the quality of health in rural Michigan and drive down costs. We'll be working with Northeastern University to do some OB work. Yeah. So they found us, from Boston.
And then what you do, John, is when you get this funding, it's oftentimes pass through. You also support hospitals like mine.
True.
And so you want to talk about that relationship a little bit?
Sure. So a federal grant program that we have is called the Small Hospital Improvement Program, SHIP. Yep. And you're well aware of it. And what it allows us to do is take a chunk of money that we then pass through to any rural hospital with less than 49 staff beds. And that's you guys along with 54 others. There's 55 across the state. And you guys work maybe charge master review,
absolutely. All kinds
quality
of
improvement,
QI projects,
QI projects, and it's a little money. It's $12,000 or $13,000, but it can go a long way in a rural setting.
It sure
so
can.
that's a pass through opportunity that we work with you guys and other rural hospitals.
Yeah. So federally mandated that the center exists, but not fully federally funded though.
No, that's a good point. I'm glad you brought that up. it's a federal-state partnership, so the feds provide money to us, and the state legislature also has to provide an appropriation. So it's $3 from state, $1 from feds, and so we match that up, and that creates our state office program. And under that program, we have workforce initiative, we do some EMS work, education manager. You guys take advantage of that with our grand rounds and Project Echo stuff. Yeah. So, and then from all of that, off of this tiny grant that's just $1 million a year, we have
Is that it?
Yeah, we have $6 million others through 15 other grant programs, and so it allows us to work in hospitals, clinics, EMS agencies.
It's everywhere.
We do clinical support with chronic kidney disease with the National Kidney Foundation of Michigan. We have this new partnership with Northeastern University looking at cybersecurity. How can we increase and protect your patient data?
Yeah. Huge issue right now.
Yeah, right. I mean, there's a lot of bad actors out there. I wish they would take that energy they have being bad and create
something
funnel
good.
To good.
Yeah.
Right. So that's the kind of stuff we're doing. Yeah.
Yeah, and so staffing. You have a team of how many?
14.
14.
Yeah. 15
Seems like
years
every Christmas card, it just keeps more and more
got
staff.
a couple more people there, and
but
they're busy.
Bright and they're talented.
Yeah.
You got an amazing team.
Well, thanks. We have one person, Jim Yates. He's up in Marquette. We have a grant, another 3-year grant where he's a Marine, ex-Marine. He served our country.
Yeah.
And he does veteran outreach. He looks for...
Is that right?
Yeah, he looks for veterans who are outside of the system and gets them back in to use their VA benefits that they so deserve.
Absolutely. And
so,
entitled to.
Yeah, and so we've also gone under the bridge, and we're working in the northeast section, Lower Peninsula, too, because we're following the data. So the data for the western UP shows that counties out that way, like Ontonagon, Gogebic, have 14 to 16% of their population are veterans, and we're finding that to be the same for true in like Montmorency County, Alpena County, and like that. So we're going down there and we're looking for the veterans to get them back in. And then we also have 3 people who work out of the United Way office in Gaylord who are doing opioid use disorder, substance use disorder work for the population on prevention, treatment, recovery, and getting them back in the workforce.
Yeah, absolutely.
Yeah.
Productive.
You got to have a reason to get up every morning.
One of the conferences I attended a few years ago, maybe it was at Schoolcraft, can't remember, but you held an ambulance forum.
Yeah.
And, one would question, why is the Michigan Center for Rural Health involved in ambulance? But my goodness, it stems everything that comes into this hospital. One of the challenges we face, John, right now is we have one provider in our county who at times will have just one ambulance on. And it's a challenge. Patients board in the ER for weeks. We have these very serious issues. But what I understand and what I heard from you that day a while ago, this is a problem across the country.
It
is the issue. Can we talk just a little bit about that?
Sure.
Because that impacts our ability to get patients out timely, impacts patients' ability to get the care that they need immediately.
Yeah.
And talk about what you're doing at the center to help resolve some of those.
Yeah, that's a good question, JJ. So this, so many of our EMS personnel are volunteers oftentimes, or they get paid by the run.
Yeah.
And we found the further north you go, some of them are volunteers too. So they'll be working at the grocery store and the bell goes off, and so they go to the EMS barn and then they take off and they go to a site, and then they go to the hospital, and then they take the barn back, and they got to take care of all the paperwork, and then they go back to work. So it's a lot. It's a lot, and especially for a volunteer. And they're also aging, right? We're all getting older, and especially in rural Michigan and rural America, it's an aging population. And so there's a smaller pool of people who want to work in the EMS world because it's tough work.
It's tough work.
It's mentally it's challenging.
Oh, my goodness. Physically
it's challenging. So
24-hour shifts typically.
Yeah. So you have all these things, and you can slip into some bad like eating habits too, because you're sitting so much, and it's easier just to go through the fast food joint rather than eat your carrots and celery, right?
Yeah.
Right. Who doesn't?
Yeah.
So what we're trying to do is address. We've been very fortunate that the state legislature has appropriated money to the Michigan Department of EMS.
Mm-hmm.
And Emily Burquest is the division director, and she's great.
Mm-hmm.
She also happens to be on our board.
Oh, I didn't know that.
Yeah.
Right.
Emily's
She was
on.
presenting that day that I was there.
Yeah,
She was there.
Yep. And so there was a carve out just for rural, and so we put together a program where we were funding folks who are EMTs to become paramedics. We need
Right.
more paramedics in rural Michigan. And I was really, Crystal Barter in our office, we were kind of like, a little scared, like maybe we weren't going to get enough applicants for the $350,000 that we had
I'm
available.
sure you probably had beyond that.
We did. We had 1.4 million.
Is that right?
Yeah. So.
Well, what a good problem to have.
Yeah, right. So Crystal came up with an idea. It's like, well, why don't we? You know what a health provider shortage area
Absolutely.
is. Yeah. So there's those for doctors, for dentists, for social workers.
HIPSA exists just about
all
for
over.
all those disciplines.
Crystal came up with the idea of why don't we have one for EMS? Why don't we put together a formula,
Smart.
right? And we can drive. We'll use data to drive resources, state or federal, into counties, into areas that need paramedics, and we're almost finished. We got a Health Endowment Fund grant to work on it. It's taking 6 months longer than we thought, but it's going to be powerful.
And so you'll use some of those funds then to funnel it to.
We have another appropriation coming in, and we'll
Good.
use our brand new EMS HIPSA calculation
That's
to drive.
incredible. Good for you.
Yeah,
It's a good method to utilize.
I think it
Fair,
is.
equitable, identifies shortages.
Yep. It's like, why didn't we think of this earlier? Why didn't I think
Yeah.
of this earlier?
That's why you surround yourself with good people.
That's right.
Right.
And then we were talking to Emily. Crystal came up with another idea, and we have an EMS program manager on staff. We're hiring for a new one right now, and we want education. Education and the protocols all come out of the medical control authorities in counties or county.
Yep.
And they're different.
They are.
They're very different across the state, and so we want to elevate everyone to the same level
That'd be
on
great.
protocols, and we just got that grant, and we'll be starting that up in January or
John,
February.
you are going to the proverbial herding cats, because let me tell you, that's across the board, the way that those are set up. I've been schooled in that. God bless you. I mean, good luck with that, because that's going to be a lot of work.
Don't talk too much about it, because our new EMS program manager could be listening. It'll scare him off.
No, it's a wonderful work. It's easy. It's going to be easy, a piece of cake. Well, then there's this other introduction that you made that day, community paramedics.
Yeah.
And that's a program, right? There's not reimbursed. It
Not
has
yet.
to be
Not yet.
right. It has to be basically paid for by the entity.
Yeah, it does. And
And
so
keeps them well at home. Explain a little bit of that.
sure, community paramedic, I consider it kind of like maybe this is too simple of a way of thinking of it, but it's a paramedic and a social worker, equal parts, shaken,
Yeah.
poured, and there you have your CP. So it's a paramedic with those type of home health,
Okay.
life skills,
Okay.
and so a hospital that's using it extensively. There's a couple. Steve Barnett and Mackenzie uses it, and then Andrew Raymond up in Kalkaska uses it. And what they do is they have the community paramedic, and when they're not busy, they're inside the ED helping out, working.
Oh, is that how they do it?
Yeah.
Okay.
And then when they
That makes
need
sense.
when
I
they
mean,
need like medication reconciliation, because
You got someone, yeah.
they go in, they look at carpeting. Oh, that could be a trip and a fall right there. So let social services know. Look in the refrigerator.
So social determinants of health as well as
Yes.
incorporating it.
Yep.
So now you piqued my interest because you said, well, it's not funded now. Is there some legislation happening?
We're looking. I know in the UP there, because there's just one single Medicaid health plan payer up there,
Yeah.
and so we have another grant up there. We're using Elise Burr over at NMU, Northern Michigan
Yeah.
University Center for Rural Health, and she's been. We're contracting with her to manage a grant up there, rural public health workforce, that's training more community health workers, but also training for more paramedics and community paramedics.
Right.
And we brought in the health system and UP healthcare system, UPHCS,
Okay.
and some Missy's group up there. And so they're working with everyone to see, where can we find funding for Medicaid to pay for the services for CPs.
Okay. Incredible.
Yeah.
Well, speaking of funding, before we get on to some more interesting and enlightening conversation, if we have some fat cats listening to this podcast, you'll take some donations, won't you, for the center?
Always.
Your 501c3, I'm assuming.
We are.
Yeah?
Yeah, we are.
So if you got any fat cats listening out there today in any state and you want to contribute to the health and wellness of rural communities across the state of Michigan, look them up. online. We'll put some information in the show notes. All right, John, let's turn to something not so fun to talk about. It's actually keeping a lot of CEOs up at night. It's the change in what we've experienced recently in federal funding. Programs that have existed for decades, programs that have been utilized, such as provider tax, through every Congress, both Republican and Democrat, through every presidency, Democrat and Republican, have passed measures to provide this funding as a safety net of sort for hospitals. Michigan went back a few years ago, and we began to participate for the average commercial rate, in which a hospital like mine received a $6 million uplift annually. That's a game changer for us. That's a difference of closing the doors. It truly is. And then we heard a lot of rhetoric of they're going to cut. I thought there's no way in the world that they're going to cut programs like this. Is the voting base of Donald Trump. There's no way that the Medicaid population is going to support cutting programs like this. There's going to be a lot of pushback. And relatively quietly, this passed. And incorporated in this one big, beautiful bill was measures that really cripple hospitals by at least 2032, but it begins in January of 27 when the take back begins. And a lot of devastation. So the federal government announces this, right? I'm on the phone, almost $1 trillion cuts, direct cuts to hospitals and communities. Now, mind you, Hillsdale, Michigan, 72% of my payer mix is Medicaid, Medicare. Government payers. These are not individuals that are at home playing video games in their parents' basement. This is my mother who was on Medicaid as a supplement to her Social Security. This is the pastor that I know is a good friend of mine who gets Medicaid, preaches at a church of 35, and he qualifies for Medicaid. These are working people. It really infuriates me. We'll talk about some of the nomenclature involved in this. But ultimately what happened is they cut $1 trillion, and the federal government says, oh, it's because of waste, fraud, and abuse, which I can tell you from my perspective, and I can't speak across the country, but we don't have waste, fraud, and abuse. We're talking about taking care of the lady that works at the Dollar General, who I know, who's on Medicaid. She's a single mom of 3, taking care of her family. That's not waste. That's not fraud. That's not abuse. I'm a product of Medicaid. 7 kids in our family, 2 parents. My dad was injured at the end of World War II, Korean conflict. My mother almost died giving birth to me, 7th child. And we were consumers of food stamps. We used Medicaid until I went to Hillsdale College and graduated. And I know we're not the face of fraud, waste, and abuse. My brother's the county sheriff. I am the president of the hospital. Successful family members who are faces of poverty, of a community where the resources weren't there for my father who was disabled to perform the work, and my mother who was injured. So at the end of the day, we cut $1 trillion, and we do it in a lie of waste, fraud, and abuse, and it sells because it's sounds good. Who doesn't want to eliminate waste, fraud, and abuse? We all do. And yet, we hear these things of the 26-year-old sitting in his parents' basement. I haven't found that kid yet because most 26-year-olds don't even want to go to the doctor, but that's besides the point. The issue becomes that the government then looks at us and says, hey, we're going to solve these problems. Yeah, we took away $1 trillion. We're going to give you some money back called the rural transformation. That's going to save hospitals. I want to talk about that because that's another lie told because it's not saving hospitals. It's not going to replace at all any of the funding we lost under the provider tax, average commercial rate. And it has to be program-based. Every state's going to be different. And the federal government may not even give it to us. They may not like our application. It might have something to do with red versus blue. Who knows? But the reality of it is that there's a lot of power being held at the federal level right now over hospitals like mine. And it's concerning, John, because what stands in the balance of someone recovering from a heart attack or a stroke is the fact that they have a local hospital available. When every second counts in a stroke, time is tissue, we say, to get that patient stabilized and mobilized, to send them to the tertiary center is critically important. But if that community hospital doesn't exist, like Albion, Michigan, not too far from here, and other hospitals that have announced closures, you're talking about very bad outcomes for patients and families. But that's a whole other kick.
Right.
What I want to talk about is the government's response to that. was politicians running around saying, well, the hospitals are going to be fine because they're getting this rural transformation money. John, talk to me about what this is. And we need to be candid here that this isn't going to save rural hospitals. But I want your perspective.
Well, first, I didn't know that about you and your family, and God bless.
Well, thank you.
Yeah, it got me a little misty-eyed.
Well, thank you.
It's powerful. There's a couple things to unpack, and hopefully we'll go back to Medicaid re-enrollment because that's going to be very important. But yeah, HR 1, depending on whose research center your information you're reading, 100 billion, 150, 137 billion over 10 years taken out of the system.
Yeah,
you'll feel it, right?
You feel it.
And when the bill was being worked, they didn't have the votes, and so Senator Hawley from Missouri came up with this concept of it originally was called, I believe, the Rural Hospital Transformation Program.
Yeah, it was.
$25 billion, and they couldn't get Collins and Murkowski, and so there was talk on the floor, and they're talking about this, and so they raised it to $50 billion, and then it became the Rural Health Transformation Program, and the covered entities include rural hospitals, certified rural health clinics, rural FQHCs, rural community mental health agencies, and rural OTPs, opioid treatment providers. Those are the covered entities that expanded. It's a misconception if anyone thinks that the $50 billion in the RHTP was ever intended to backfill the cuts that we'll be seeing over the next decade pay for tax cuts. It's not there, and so it was set up, and every state had the opportunity, and every state did take the opportunity. The notice of funding opportunity was set up like a HRSA grant, which we're familiar with, and it was all sent to the offices of the governor, and everyone then had to make a choice on who's going to write it. And in Michigan, it went to the office of the governor, and then there was a group of people in health policy and planning in the department who wrote the proposal, wrote to the NOFO. You have to write to what you're reading,
right? Regardless if you like it or not. Yeah, you have to write to it.
You have to write to it, and we saw the NOFO, and it was thick. There was a lot of pages. We went through it a few times, and you had to have a needs assessment and the budget work, or the template, and they wrote to it and got it out in time, and they only had like 45 days, 30 days to write it.
Short turnaround.
Very, very short turnaround for writing to $200 million a year over 5 years. It sounds like an incredible amount of cash. It is an incredible amount of cash, but it doesn't address the issue that you're facing and all the other hospitals and FQHCs and RH are going to face, which is money's coming out of Medicaid, and while having new programs thought of and funded in workforce, or having money set aside for technology or chronic disease or care closer to home, those are great. That should have been part of keeping what you already have in Medicaid,
That's right.
and then having this in addition
Supplement. Correct.
Right? And so missed opportunity. It never was intended to backfill any of the pain that you're going to face here in Hillsdale.
Not at all.
No.